it mean that it happens through fantasy? Is that a very important component?
That's very important. So what Judy is reminding us is that in reality, you can do very little, right? But you can engage in an omnipotent fantasy, and fantasy with a PH. You probably realize that Blandonu spells fantasy with a PH, which is different from fantasy with an F. The fantasy with an F is not a psychoanalytic concept. Fantasy is, oh, I have a fantasy, I want to travel to Hawaii. No, it's not about that. It's a fantasy with a PH, meaning something that your mind creates and that in totality or in part of your mind you take for a fact.
You what?
You take for a fact.
Uh-huh.
Right? You live in that fantasy, or you live out that fantasy.
Unconscious fantasy.
Yeah.
Well, yes, but the effects of that unconscious fantasy is very real. If you go psychotic because you have the omnipotent fantasy that you can attack your psychic apparatus, your psychosis is a fact. You become, in fact, psychotic. Anybody could say that. A psychiatrist would certify you as psychotic. The way you got to become psychotic, that is unconscious, that you don't know. And psychiatrists don't know either because they don't understand psychodynamics. They understand symptoms and what goes on in the brain and all these things, right? So we are saying it's a fantasy, an omnipotent fantasy where you can use your mind against itself. Denial is such a fantasy too, right? Because let's say that someone tells something to you that is too painful for you or too hateful for you to hear, and you hear it but you deny it. The denial is a fantasy because something has been told to you and you did register it and you deny it. So you register it but the denial, and then you're living as if you never heard of that. That is a fantasy.
Like when you
An
tell a
omnipotent
patient,
fantasy.
like when you tell a patient that you're going away and they respond as if they've never heard of this information.
Exactly.
They've done away with it. They haven't held their information.
That's correct, right.
But aren't there then lower extremes of psychosis?
Well, we'll see.
Okay.
There are lower extremes of defense mechanisms. I'm not sure if I would say lower extremes of psychosis, but certainly there is a whole range, of course. But we want to try now to dissect the differentiation between psychosis and no psychosis. That is what Bion calls psychotic and non-psychotic personality. Right? I mean, just grossly speaking, but then you're right. I mean, there are different ranges within psychosis, right? Now, yes. Go ahead.
Can I ask a question?
Sure.
He also says something about how whatever the action of the dominant drive is, life or death, in the psychotic it's immediately mutilated by the other one.
That's correct.
And it seems to me that when a process like that is going on, the patient, even if not psychotic, but even, I think that process can happen as well, and the patient feels like they can't move at all. They're very stuck in this cancellation rather than integration of the drive.
That's correct. Right. I mean, you're very busy, or rather, the conflict, the inner conflict between destructiveness and creativity, or between love and hate, fighting with each other, keeps your mind so busy that you have little impulses, let's say, little drives to move on into anything other. intellectual, social, or work, or whatever other thing, because your mind is too busy caught in that conflict. We know that in less extreme cases, here to take what you were saying, for instance, in very severe obsessive compulsive disorders, you can see that the problem of a severely obsessive compulsive patient is that he can't do any other thing than live out constantly his obsessive compulsions. He goes on and on, right, over and over his rituals, and he can't get himself out of house to go to his job or to relate to his friends or to a partner, because he's all the time trying to cancel with one hand what the other hand is doing. Too busy. Right?
It's such a painful thing to watch, you know, that stuckness and repetition, and it's so hard to get in the middle of that somewhere.
Well, precisely because the patient is too busy. It's being kept busy. It's not that the patient purposefully decides that he won't listen or she won't listen to you. It's just that there is something else keeping the mind busy.
So that all-consuming back and forth is a struggle between the life and the death instincts, ultimately?
Yes, ultimately that's it.
Even
Yes.
in OCD?
Yes, absolutely. Absolutely.
So why do medications help people with hallucinations? They stop hearing voices and stuff. I mean, if that helps them, they stop hearing voices.
Right.
And you haven't discovered anything about their life and death instinct or conflicts.
I think that's a very good question. It's
Can I say something?
Go ahead, yes.
My experience with capital P psychotic patients, and certainly you tell me your experience with them. She and I worked together at a psych hospital for years. They don't like how the meds make them feel, and they also don't. They would prefer to be off of the meds because of how they're deadened inside. They don't like the experience of the meds.
One of the things that Tony Stanton said in the Saturday Dialogue, he's a psychiatrist, and he was discussing medications. And one of the comments he made about medications, it was of course a very overview, kind of a very general comment, but he said that in general he thought that medications tamped down the activity between the different functional modules in the brain.
Mm-hmm.
yeah.
And so it was more inhibiting general brain activity, and as a result kind of decreasing psychosis maybe in that way. I'm just kind of...
I think
So
that's
that, so that in this model,
that's
then,
a good response.
But it doesn't deal with the conflict.
No,
It doesn't deal with
Right.
the conflict.
but it would
No.
diminish the attack because it's diminishing everything else.
It's diminishing everything else.
Right.
Sure.
Yeah.
But if you had a dynamically oriented therapist who may or may not be medicating, or may be an additional therapist to the medicating psychiatrist, an appreciation of the obsessive compulsions would seek to understand the function of those compulsions, wouldn't they?
Oh, yes.
So the reality is that the patient's life becomes one big ritual, from which there is no escape.
Yes.
But a dynamically oriented interest would seek to understand that as a communicative function, which is directly the opposite of the medication, isn't it?
Yes. Exactly.
And how does that work in terms of the compulsion actually acting as a communication? It's there as a communication, whether or not someone's listening.
Wait a minute. I'm going to give you a quick response, but I don't want us to get
Okay.
too much into that because we want to answer your question, which actually is the essence of this chapter and the next two. That is, how does the attack on the apparatus happen? I mean, I was just giving an example about why it happens, and to take a picture, a clinical picture that we're more familiar with. Not all of us have seen many psychotic patients, but we know what an obsessive compulsive disorder is. That's why I brought the example, right? It's the fact that a dynamic-oriented psychotherapist may understand the conflict of an obsessive-compulsive disorder doesn't mean that the function of the disorder is communicative. It just means that if you understand it, you say, well, your illness is telling me this and that, but that doesn't mean that you want to communicate that to me. Actually, if I tell you what your illness means to me, you may feel very displeased and very unhappy, and you may want to never come back because you don't want to know what that means to me. Therefore, it's not having a communicative function, it's having a defensive function, and a very poor defense because it never gets resolved. You're all the time deciding, do I do this, do I do that, but you can never decide what you want to do because one wish has to fight the other, right? But let us get back now to your question, and now we will little by little get to your other question, you see, that is, what are bizarre objects? All right, so taking that, in an extreme, if reality, external and internal reality, and we gave the different examples and how injuring to a person that is narcissistic, meaning that has a low tolerance of frustration, external and internal reality are, the human condition is injuring for someone who has a low tolerance of frustration, then in an extreme, you can't change the world, you can't change your inner reality, then you resort to this omnipotent fantasy, to the omnipotent fantasy that you can change your awareness of reality, inner and outer reality, or of all that that you can't bear, right? You were talking of denial. Well, certainly denial, well, yes. The denial would be one way, but denial doesn't make anything to your apparatus. Because in the denial, you are still registering, and you are denying what you register. Sort of, you're unconsciously telling yourself, that can't be true. And then you go on living, unbelieving, not believing that what you heard is true. You just decide it can't be true, so it's not true, right? But your senses are still registering, so you have to continue denying, right? Say, that what I see can't be true. I'm seeing it, but it's not true, right? But a deeper attack is, and that is psychotic, is the omnipotent fantasy that you can attack that aspect of that function of your apparatus that is informing you of that you don't bear to hear or to see or to experience. In some way, it's the intelligence used against itself. In a paper that I presented years ago in CORE, I called that counterintelligence. Counter/intelligence, the intelligence against itself. You see?
So the mind is attacked so that it won't perceive what is really there in fantasy.
Exactly. Now, the omnipotent fantasy so goes beyond, at least in describing the psychotic personality, is that you can split, and by split Bion means fragment, that you can fragment your apparatus of perceiving, and that you can then, for instance, fragment your ability, let's say, to hear. It's not hear, it's not the neurological hearing, you're still sensitive to sound. It's the sense of hearing connected to consciousness. That is, your ear would still function, you do hear the noise. What you attacked is you're making meaning of the noise. Right? I talk to you, you hear me talk, but your ability to make meaning of what I'm saying, that is what gets attacked. That's why we talk of the psychic apparatus. Nothing happens in the body. Your sense of